myeloma cell to die and you to respond to treatment. So it is all these, some of the agents I'm going to mention are linked to these different abbreviations and terms. And it is also a greater understanding, particularly with bones, as to a vicious cycle that is set up between your plasma cell producing a variety of what we call cytokines or chemical messengers that say to the bone, we need to eat more bone, and then the bone says, thank you very much for allowing me to eat bone, I will send a message back that allows you to live, and a vicious cycle occurs. So a lot of the agents coming through are called inhibitors or blockers, so proteasome inhibitors. They're inhibiting these pathways that allow this to occur, and they're doing it in a far more targeted approach. So these newer targeted therapies are a little bit more clever than chemotherapy, which is like throwing a sort of bomb at your disease and just annihilating whatever comes in the way. And this is going to be where the future lies. A whole rack of different agents I've put there, and you've got them on your slides, showing different families of new agents that are coming through. What is good to know is that these agents all work well together. I don't think any one drug is coming through that is going to cure the disease, but there's increasing numbers that come through that are aiming to manage and to have an effect against the myeloma and put it into a form of remission. And these different markers here and targets all act in different ways, including some that are particular just to bone. This is a particular agent which is aiming not so much to attack the myeloma, but to protect your bones from the onslaught of the myeloma. So there is not only progress being made in anti-myeloma agents, but also in supportive care agents, bone supporters, agents that perhaps give you a better fight against infection and things like that. So supportive care as well as anti-myeloma care. John was asking about whether the need for high-dose chemotherapy and stem cell transplant will still be required in the era of novel agents. And that's a question that is being addressed by a variety of big myeloma research groups around the world. And the early data on that is suggesting that we're not going to be throwing away high-dose therapy and stem cell transplant, given that managing myeloma is about getting mileage out of each line of treatment. Why would you throw one of them away when each newer agent is not replacing the others, it's just providing an alternative. So it's very early data, and what we do need to happen is for time to pass with these studies. People need to have, but the studies principally are looking at combinations of drugs which exist now. So the combinations they're talking about are the newer IMiDs or immunomodulatory drugs such as Revlimid in combination with perhaps say Velcade and a steroid. And if that combination of these novel agents is intensive enough to do the same job as putting you through a stem cell transplant, and they have some head-to-head studies which is putting one group of patients through the say Revlimid Velcade for say 4 cycles, one line then goes through to stem cell transplant, the other line continues with more cycles of that treatment, and then after they both end up on a maintenance setting of perhaps lenalidomide, which is Revlimid, which is the same thing. And the early data on that, but that time needs to pass. So we need to wait years for patients to start relapsing in both arms, and probably a good 5 to 10 years to find out what the long-term data is. Because sometimes one arm does better in the short term, and then actually in the long term, the other arm actually does better. So early data is suggesting that certainly the high-dose therapy with melphalan and stem cell transplant has an effect against the disease that is worth retaining. And it may actually, in some of the studies, and there's various groups are addressing that exact question, there is slight differences in the data that's coming through. But actually in some of them the stem cell transplant arm is actually doing a little better than the other arm. Again, we need to wait for time, but I don't think transplanters are throwing that option out, particularly given it's about having as many options in your pharmacy basket as you possibly can have, so why throw one away? But always that balance. You know, it's not pleasant. Who's been through a stem cell transplant in this room? Yeah, a lot of you. Who would do it again? Yeah, some would. Maybe, perhaps. if the results, and it's a fair point, isn't it? If you can provide me with evidence that actually I'm going to get some benefit, I will perhaps then manage and be prepared to undergo a higher toxicity regimen or to be under greater distress. But if you can't, you know, if you're telling me it might make a month's difference or something, I'm not prepared to go through that distress.
4 years without any treatment.
You've had 4 years without any treatment, did you say? Yeah, fantastic. And I've got patients, I was showing the girls last night actually, just to describe how individual this disease can be. And we gave a lady just some gentle chemotherapy about 6 years ago before we really had access to thalidomide up front. And a stem cell transplant, and her disease is in what we call CR, which is complete remission, 5 years later. And she actually presented her hematologist with a silver pen at the 5-year anniversary. Yet I have other patients who we've had to really struggle to keep them in any form of stability. So you're right, and that actually impacts on when people ask me, what do I have next? When it comes back, what's the best regimen for me to have? And it depends on what you've had before and what worked. This lady who had a stem cell transplant, it clearly has done very good for her. She may well actually be suitable to have another one because she responded so well. Yeah, so time will tell, but I don't think any of us are prepared to throw transplant out of the basket quite yet. And I think it's going to remain there for time to come. It also is a more cost effective, and we need to be realistic in the cost. If you can imagine 2 of these novel agents for perhaps a year would weigh up, you know, build up to a considerable amount of cost and a considerable amount of toxicity for you. You'd be taking a tablet or 2 every day. You might be coming in to have your intravenous medication, whereas a transplant is perhaps maybe a shorter period of intense unpleasantness, but followed by a longer period of nothing, perhaps. So that's another thing to weigh up. Yeah. Be nice to get in a time machine and jump 10 years forward and pop back, wouldn't it? Yes, this gentleman here and then...
Tracy,
yes.
May I have your explanation of the word remission?
Remission, yes. So remission, there are a lot of terms we use that help to describe response. And within that response, we use the word remission. So, and around the world, different groups use slightly different response criteria. But the basic ones is we have different stages. And the more we understand about myeloma, we actually have to adapt those response rates. Because what we thought was remission before, complete remission, which we term CR, would be an absence of any measurable amount of your myeloma. So if we did a bone marrow, we would see normal healthy plasma cells at a value of less than 5%, and we would see no immunoglobulin in your blood or your urine, and you would be otherwise not compromised. So you wouldn't have active bone disease, and your kidneys would be fine, and your blood would be good. That would be remission. These days, technology has improved at a laboratory level that we can actually see what we didn't see before. So we've had to move back the marker for remission, and we now have a complete remission, a stringent complete remission, and a molecular complete remission. And those different forms of remission are based on minute measurements of the presence of your disease in your body. But generally speaking, remission describes the absence of us being able to measure your myeloma in your body, in your bone marrow or your blood. But the remission does not mean it's gone away forever. We also then describe a sort of stability or a plateau, and that plateau is a balancing, a steadying of your markers, your paraprotein hitting a plateau. And it's not so much what that figure is, your protein at that plateau, it's the leveling out and the plateau effect. So for example, I've got a gentleman we've looked after who has a paraprotein of between 40 and 50, but it's in plateau and it stays there and it doesn't get any higher, and he is not compromised by having a myeloma protein of 50. He has no bone disease, kidneys are fine, and his blood is strong. So he is in plateau and we do not intervene. I have another gentleman who goes between 2, 3, 4, 5, and he's very, very unwell. And his, so it's the measuring and the graphing of that protein level. We would not describe him as in any stability, yet he has far less of the markers of his disease present. And this lady here was asking a question.
Is the P50 gene inherited or a result of the disease?
P50?
Yes.
I'm not sure. This lady was asking about the P50 gene in myeloma. There are specific abnormalities, typically something described as T414 and deletion 17p, which are known to be at the time, abnormalities that occur in patients with myeloma that occur at the time of the disease. I'm not aware of P50. I know those are 52. I would imagine, it sounds to me as if it's an abnormality that occurs at the time of an illness. And if that is related to myeloma, that it's occurred at the time your plasma cells that have been otherwise healthy have suddenly become unhealthy. And they've become unhealthy because something in the DNA that allows the cell to replicate, and these cells divide very quickly. There are cells in our immune system that will be replaced by the time we leave this room. You know, there are very, very, very rapidly dividing cells. I would imagine that is related to an error occurring. But there are a lot of errors that occur in plasma cells at the time of a diagnosis of myeloma that are not thought to be particularly bothersome. They explain perhaps why the cell is misbehaving, but they don't suggest that the cell will be aggressive, whereas T414 and deletion 17p is a more aggressive form of disease, but on the other hand, it also helps to tell us that Velcade actually responds better to T414. So if somebody did have that, we'd probably choose a Velcade-based regimen for that patient, and then they do better. Yeah. So we're going to move now on to the area of managing the complications, which is what we're supposed to be talking about in the first place. But really do stop me if we don't get through all the slides. You know, my goal is really to talk about and to have discussions with things that are of interest to people in this room. Okay, so do keep doing as we have done. Okay, so when we talk about managing the complications or the side effects, there are so many, but if we were to think of a few different areas to focus on, we would probably think of the areas that myeloma cells particularly seem to attack or disrupt. And that would be that these myeloma cells obviously are in the bone marrow. They are potentially, because they're increased in numbers, disrupting the normal function of the bone marrow, which is the factory of the blood and to produce blood cells. So it's not surprising that managing and monitoring your blood, if any patient comes into our clinic and sits down for long enough, we take their blood. And I'm sure that's probably the same over here. And I have to say to people, you know, sit there and wait for me and don't let the girls take your blood, because you have to put your hands behind your back or something. But we do need to keep an eye on your blood, because it can be compromised because this is a blood disorder. So that's very commonsensical, and we'll talk about how perhaps that happens typically. We also know that these plasma cells, particularly when there's a lot of them, produce a lot of this abnormal antibody, and that is present in the blood or the urine, and can cause the blood to become thickened and can cause difficulties as it passes through the kidney. So the kidneys are the filters of your blood. So anything you have in your blood that is not meant to be there, or particularly if it's a larger molecule, can cause distress to the kidneys. So we'll focus on how the kidneys can come under attack and harm. And then also these myeloma cells have a destructive relationship to bone. There are two cells in the bone, the osteoclast and the osteoblast, and they are forming and breaking down bone at an equal rate. As we all get older, particularly women, we tend to have a thinning of the bone, but nevertheless you should have a basic equilibrium. And what happens is that myeloma cells disrupt that equilibrium, so you have a sort of sped up osteoporosis occurring, and you can have what we call lytic lesions or punched out holes in your skeleton, and that can certainly be painful, or it can also fracture and need intervention.